Thank you so much. I wanted to start with a little introduction of the University of Iceland and sort of the new work that I've been sort of engaged in during the past few months. And then I will sort of go on to sort of the subject of the day a little bit later. Yeah, you see the campus here, sort of, and this is approximately a month, sort of this is the season that, we're entering the duck season, right? And
Okay, that's it.
no, right?
Yeah. No, yes, you saw it, yes.
And here is another picture of the campus. This could look very resemble what it looks now, actually, when I look out of my window, except there is no volcano erupting right now, but they're saying it's in a matter of days or weeks when it will happen again. It last erupted 800 years ago, but started to erupt during COVID in the same pace as it did 800 years ago. And it seems very close to our campus, but it's maybe 40 kilometers away. But it sort of gives you a feeling of what we can see from Reykjavik, where University of Iceland is situated. But it was founded, our university, in 1911. And it is a national university and basically the only university. We have a couple of colleges also in Iceland. It's sort of a state run, so it's the tuition is quite low, as you see. It's only $550 per academic year. And my daughter studies here now at the school where I work as well. We have approximately 14,000 students and approximately 2,000 employees, perhaps around 3,000 additional sessional teachers. We have 5 schools at the university: arts, education, engineering, and natural sciences, and then health sciences and social sciences. And as mentioned, I belong to the School of Health Sciences, where we have in total approximately 3,000 students and 500 staff, faculty and administrative staff. And as Bert indicated, the school encompasses a few sort of faculties, 6 faculties in total. Faculties of nursing and midwifery, pharmaceutical sciences. We have a school of medicine. We have approximately 75 students that we accept through competitive exams each year to the program. We have food science and nutrition faculty, faculty of psychology and dentistry. And then we have, of course, graduate programs that are interdisciplinary in biostatistics and epidemiology, for example. That's relevant for you guys in public health sciences. So this is sort of my learning curve during the last 6 months has been devoted to this structure and sort of the opportunities that this structure has, along with the challenges of the individual departments and faculties. But we do have very, very interesting data sources in Iceland. Of course, we have the nationwide population-based registers that are identical to the other Nordic countries. We have quite extensive genetic resources at Decode Genetics, where actually my other office is. We have clinical data at the National University Hospital, where I actually sit now, and the School of Health Sciences sort of main campus is. We have some interesting cohorts, the Reykjavik Ages cohort that Lorelei Mucci and I have leveraged quite a lot, actually, in our studies of sleep and melatonin and prostate cancer. We have the SAHA cohort that's focused on women's health and trauma. And we have the iStop MM, a really large cohort on multiple myeloma in Iceland. and sort of is population based and focused on risk factors of multiple myeloma, and has approximately 75,000 individuals enrolled. And we have leveraged these resources in collaboration with the other Nordic countries and Estonia and Scotland, where we have, for instance, in COVID, collected data in a harmonized, systematic manner in these cohorts, and which has been really, really rewarding collaboration funded by Nordforsk, which is sort of a Nordic research fund. And we've published some quite a lot of work there, and it's been extremely rewarding for our doctoral students and postdocs, and particularly I'm just giving this as an example where we basically demonstrate and are now very much focused on sort of the long COVID problem, or this new phenotype that we are dealing with, where we have actually revealed that early or sort of the acute illness severity is very, very much predictive of sort of long. You see here in red, those that were bedridden, individuals bedridden for 7 days or longer during their illness have a higher risk of multiple physical symptoms more than 2 years after being diagnosed. So this is what some of the examples of the sort of Nordic, Northern European work that we've been engaged in. And we, as the Center in Iceland, have been leading this work in collaboration. But yes, as an example, further examples of collaboration with Boston, we've been collaborating with Professor Smoller, who is leading the COVID Global Mental Health Consortium. We've also signed an MOU with MGH Institute of Health Professionals that was done this summer, actually a month before I entered my position, but we are starting with a student exchange. So some of our medical students are going there to Boston next winter for a research project in Boston. And we do have long-standing collaborations with Chan School of Public Health, and we've leveraged Rose fellowships for these exchanges. So some of the students of the School of Public Health have come here. But the subject of the day is sort of my main research area, and sort of I remember that I sort of maybe in January 2020, I wrote an editorial in the Icelandic Medical Journal stating that trauma and mental health was one of the major public health challenges of the 21st century. And then a month later we had COVID, and the sort of the focus shifted a little bit. But I have been sort of intrigued in my research from the fact that during the lifespan we are exposed to different sorts of life events, and these not only tear our psyches, but they can also influence considerably our physiology and our immune system and cardiovascular system, and can make us very, very much exposed to a lot of, or vulnerable for a lot of different diseases. And I'll show you some examples of this. I'll show you some examples of what we've done on loss of family member that we have been, my group and others, been focused on, and many, these are the kind of life events that many have focused on for many decades. I'll also show you some data on cancer, the sort of the traumatic event of receiving a cancer diagnosis. I'll show you some data on violence and trauma and stress-related disorders, and then I'll end with adverse childhood experiences that are unfortunately very, very common in our societies and have considerable health impact in adulthood. And I'll sort of, delve into sort of how we have used family-based design to control for unmeasured factors like shared early environment and genetic factors. using the registry. So the idea is basically, I mean, we know that siblings share genes. They share early environment, including exposure to trauma in many instances, but not always. There's a clustering of behavioral factors within families. This is documented in multiple studies. We also know that diseases cluster within families. And so we've used these sibling comparisons to control for these time invariant factors that cluster within families. And I want to acknowledge Arvid Sjölander, who is my mentor, biostatistician, professor of biostatistics at Karolinska Institute, who's written a lot of very, very nice things, and everything I know about these designs and is from him. So I want to just acknowledge him here. And so for those of you that are not familiar with the Nordic registries, we sort of they contain in total data on approximately 28 million individuals across the Nordic countries. These registries are quite similar, I would say, in many cases identical. We assign at birth or immigration a personal identification number that follows you throughout life, and these numbers are registered when you use the healthcare systems and are attached to the diagnoses that you get from birth to death. So we are leveraging these resources a lot in our studies. But what we also have is the multi-generational registers, which form the family links between individuals, or like the family ties between individuals. We have this information basically in Iceland from settlement. It's not a big country, but we have and a very a country that likes to register everything and write stories. So we have quite good documentation of this from the 900s. And we have quite good coverage and really 100% coverage of individuals born after 1932 in Sweden. And then we have these twin registers as well in order of the Nordic countries, and I'll show you some examples later on using the Swedish twin register. And what we typically do using these registries is that we, in these examples that I will show, that we identify individuals that are exposed to a given life event or a traumatic event, and we select age-matched individuals randomly in the population, somewhere between 5 and 10 individuals per set. It varies a little bit between studies. And then we identify the full sibling, so sharing both biological mother and father to compare with, and these form a separate set of comparisons in our studies. So going first to loss of a family member, this is what we have been doing a lot, and other groups as well. This is a Danish study from 2003 by Lee and co-workers in Aarhus, and they demonstrated following parents that had lost a child younger than 18 years old, on elevated mortality rates, particularly among mothers after loss of their child. And what we were interested in Iceland is that we could have a quite interesting scenario after because we have so long follow-up here of through the multi-generational registry that we call Íslendingabók. And so we wanted to look at the differences in health effects of child loss potentially during different times in Iceland, very different times. You see that, you know, I'm just taking this as an example, the infant mortality rates in many developed countries today is around 100. In developed countries, perhaps less than 8. Iceland has one of the lowest infant mortality rates in contemporary times, But in the 1880s, it had really, really high, you see, like one of the highest ever documented in history, actually. So the scenario was how when you are expecting that maybe a portion of your children will die, how does that impact potential health effects in the population compared to today? And the answer was that we actually using this resource so that there was very limited, there was always an increased risk of premature mortality among mothers that you see here in red, both in the 1800s and also in contemporary time. And these comparisons, these were in total based on 47,000 parents who lost a child during the entire follow-up. And we compared always with the mortality rates to their full siblings. So there we got at least the answer. And it was very useful because we didn't have a lot, we had no other covariates, basically. I mean, we had number of children and all of these things, and we knew where they resided, but we had basically no other covariates. So this was a very useful way of looking at these mortality rates. But yes, both in very poor realities where you are experiencing high mortality rates of children, and also in very, very rich society as Iceland is today, you see similar impacts on parental mortality after child loss. And in contemporary times, back to contemporary times, Young Lee and co-workers, they've also shown that individuals that suffer child loss have increased risk of being hospitalized for psychiatric disorders, which is not what you would expect. And in this year, actually, Yufang Chen published his first paper on these who's postdoc with me and my friend Fang Fang and Donghao Lu. Published his paper and on where he had identified in the Swedish registers approximately 50,000 individuals that had suffered assaults. More than 500,000 individuals that had suffered injury or accidents, and then more than 300,000 individuals that had suffered bereavement, either loss of a child younger than 18 or a spouse. And then he sort of randomly selected non-exposed individuals, matched for age and sex, and then compared to full siblings of the individuals exposed to trauma who were not exposed to these similar trauma as these individuals. And so here you see the result, and what was really quite striking, you see the yellow is the sibling comparisons and the hazard ratios that are sort of smoothed by the flexible parametric models, but you actually see the extraordinary high risks during sort of the first year or the months passing after child loss. But basically we see very limited influence of these familial factors as sort of the population comparison, and those results resemble very much when we actually compare to the full siblings. And here you see sort of the risk of all measured psychiatric disorders that were elevated, both in the sibling comparison and the population comparison, and actually very, very little in some comparisons, some drop in the sort of from the hazard ratios observed in the population compared to sort of the sibling comparison, except for schizophrenia, which was null in both comparisons. And this applies to either loss of a spouse or child. Another branch of our work is on the cancer diagnosis, and 12 years ago, this is my dear friend Fang Fang, a collaborator at Karolinska Institute, and this is a paper that we did using the Swedish population and basically reported a dramatically increased risk of suicide and cardiovascular deaths. There was always sort of, and yes, I wanted to say that Fang Fang and her group have just published this paper also in JAMA Oncology based on the Danish population, basically showing similarly increased risk of suicidal attempts and suicide deaths among spouses of patients who are diagnosed with cancer. And you see, well, a similar pattern of these dramatic increase and then lowering with time, but still elevated many years, 2 decades later, and same with suicidal death here, sort of among the sad but really important discovery that the spouses need to be taken care of. But back to the patients, Donghao Lu, who is a former postdoc at the School of Public Health, the Chan School, and was a doctoral student with Fang Fang and myself. And this is from his work where he followed patients during the sort of the diagnostic period, starting before, actually the 2 years before the diagnostic period, and was documenting incident psychiatric, the first documented psychiatric diagnosis among these patients. And you see the dramatic increase just after, but also sort of during the year before diagnosis, actually a rise in disorders in this patient population. And you see how sort of many years, how the risk is actually of the first documented psychiatric diagnosis is increased in this population. And what we have done now also, you know, we in the Swedish registers, we have a lot of data on socioeconomy and so on, but we do not have data on behavioral factors or these things. So we repeated, and Fen Fen, my postdoc, repeat this analysis using the UK Biobank, where we have a lot of data on behavioral factors, BMI, we do have smoking and etc., and actually saw a very similar pattern of the first psychiatric diagnosis among these patients. And you see, this is the first year, and you see how there is an elevation during the entire follow-up. And then we did a parallel analysis in the Icelandic population, where we first compared with the population controls, and you see the elevation here. And then we repeated the analysis using full siblings as control who were not diagnosed with cancer then. And you see that there is an attenuation, but very little, I would say, attenuation. There is some, but very limited attenuation in that. This is ongoing work, and I'm sorry for the quality of these graphs. They might get a little bit improved before submission. And so another finding from our earlier paper was this cardiovascular disease deaths after cancer diagnosis that rapidly increase and then are attenuated during the first year. And we actually did this analysis, repeated this analysis, Kwan Song, a collaborator of mine and her group in the UK Biobank, and where we actually do the analysis stratified by polygenic risk scores, by tertiles, polygenic risk scores for cardiovascular disease. And we see that the attenuation among cancer patients is always, this is just during the first 3 months after diagnosis, it's always increased in all strata, and also by family history of cardiovascular disease. So I'm going to proceed to violence. It is a sad fact that, you know, worldwide, 1 in every 3 women are exposed to violence during their life course. And this has sort of gradually taken over my interest, I must say, as an epidemiologist, and sort of coming from a country with sort of high gender equality index, and is still knowing about the high prevalence of this has sort of sparked a very high interest. That we need to study this more, and this needs more emphasis with respect to health outcomes. And you see exactly in societies like, you know, the Scandinavian societies, we have, this is data from this report in 2018, sexual or physical violence in relationship, and you see the Nordic countries being very high, and Iceland as well. And as I mentioned, you know, in spite of, you know, we are for approximately, I think, 10 years, we've always topped, you know, the sort of the gender equality indexes of the World Economic Forum. So after receiving a quite extensive grant from the European Research Council, we started a cohort that we called Stress and Gene Analysis Cohort, which is focused on women. You see, these were our sort of spokespersons. Katrín Jakobsdóttir, our Prime Minister at the time, where we sort of started sort of a national gathering of information, basically documenting the life stories of women in Iceland. And the aim was to understand, of course, the genetics of post-traumatic stress disorder, but also to just understand the prevalence of various traumatic events, but, you know, focused on violence, and understand the association between trauma and multiple health outcomes in a better way. We invited approximately, virtually all women that we could identify with a registered address and telephone number in Iceland in this age range, basically adult women and still working. And we got approximately 30% responded, and we have genetic data on most of these. We've done a second wave of these, and approximately half of them participated earlier this year. We are extremely excited to see that our study population, although we have a little bit less than a third, resembles quite well the Icelandic female population. We see that it was a little bit hard to capture this group. You see our cohort here, the SAA cohort. And this is sort of the age distribution in blue in the Icelandic population. We had a little bit of overrepresentation among educated women, but basically salaries, the geographic location or residency is very similar to the background population. The results show, these are just early results, that we have 40% of Icelandic women, or our cohort, state that they have endured physical or sexual violence, which is unfortunately not surprising. We have had other studies similar, both in other Nordic countries and also other surveys here using another kinds of methodology. These were questionnaires that they responded to, electronic, sort of on the web-based questionnaires that they responded to. But we have seen these figures before, and and the uniqueness of the study is the sort of the very fine phenotyping of multiple different kinds of trauma that women are exposed to. We've published some focusing data on workplace, specifically focusing on workplace sexual violence, seeing that it varies a lot by branches that women are working in. Unfortunately, healthcare being quite high, things like education that is like, you know, 80% plus women. It's quite low with contemporary exposure, and that ever exposure has, and you know, exposure to sexual violence or assaults in the workplace have very large impact, I would say, on both psychological health and physical symptoms, and suicidal ideation and harm, self-harm, unfortunately. And Edda Björk Þórðardóttir has also been looking at probable PTSD and the prevalence of probable PTSD. And it varies a lot by trauma type, with sexual assaults being the highest proportion of women that have endured a sexual assault, that sort of over a third of women that have been exposed. And these are often assaults that happened decades ago, and that are a probable PTSD case. And we are now in the process of developing interventions, make them more accessible for these women, to sort of be able to function better in societies. And we're using sort of our cohort as a platform for randomized clinical trials. You found more on the study that I was telling you in the Swedish population. Here we actually see, when looking at assaults, we see again, the yellow is the sibling comparison, and the blue or the greenish ones are the population comparison. And you see that there is some influence of familial factors when looking at first incident psychiatric disorders after exposure to assaults. And we see this also for sexual assaults. But what I want to, this is mainly driven, I would say, for association. Here you see substance abuse, where you see a large attenuation by sibling comparison, and then also for PTSD, a considerable drop as well. But anyway, we see also when we compare to full siblings, we do see these influences of these extreme events on risk of psychiatric disorders. So some of the branch of our research has been sort of looking at, of course, there's an enormous resilience. So not everybody exposed to trauma and, will develop, serious illness or diseases. But probably those that develop severe psychiatric problems after being exposed to trauma, stress-related disorders, we have shown, and Juan Song is the driver here and was a postdoc with me just before COVID, has shown in multiple analyses using the Swedish population that individuals that have been diagnosed with stress-related disorders, and these are disorders that are only diagnosed after events. These are PTSD, post-traumatic stress disorder, acute stress reaction, adjustment disorder. These are psychiatric disorders diagnosed after index events. So she's shown associations, and using precisely sibling comparisons, association with autoimmune disease, cardiovascular disease, life-threatening infections, neurodegenerative disease, and all-cause mortality. I won't dwell into that. I'm sort of trying to hurry up here a little bit. This is our paper from 2018 or 19, I think 18 maybe. Basically showing where we tested the association between stress-related disorders with subsequent risk of autoimmune disease, and 41 different autoimmune diseases. And we got positive association for 18 of these, and also when using a sibling comparison. And I'm just gonna, there are some examples here of lupus, thyroid disease. These associations varied a lot. We also, just maybe a year later, published a study on life-threatening infections. These are things like sepsis, endocarditis, meningitis, and other serious CNS infections. And here you actually see quite nicely the differences by age of the diagnosis of the stress-related disorder. And here you see the full sibling analysis and the population analysis. And actually the patterns are quite similar. There's a little bit attenuation in the sibling analysis, but not dramatically different. And here is another paper of one's focused on neurodegenerative disease, and just focusing your attention to sort of vascular neurodegenerative disease, which was quite, seemed very much influenced by the exposure to stress-related disorder. And there's actually a very similar findings in both sibling and population comparisons. And another very, very similar study by Fan Tian, looking at all-cause mortality. And here we actually saw very, very similar results for the sibling comparisons compared to the population comparison, increased risk of all-cause mortality. But the sibling comparisons, don't be fooled by this. The sibling comparisons can actually refute, or they do not always confirm our findings in population comparisons. And I wanted to show you this study by Yu-Shen Li. As you know, many perinatal factors during pregnancy and birth have been associated with the various psychiatric disorders. And this study nested in Sweden, we looked at pregnancy-related factors and birth-related factors and risk of stress-related disorders in the offspring. And I just want to highlight here some of the, if we had been stuck with our population-based analysis, we probably had been quite bold with many of the interpretations here. You see young paternal age, young maternal age, maternal BMI, maternal cohabitation status, and even birth for gestational age, like low birth weight for gestational age. All of these were largely attenuated to null when we utilized the sibling comparison. Sort of leading us to sort of more of an interpretation of that there are probably more likely to be sort of biologic genetic factors that are influencing these association rather than the actual exposures during pregnancy or birth. The last chapter here is on adverse childhood experiences, and I'll do that very fast. It's a strong risk factor for adverse health outcomes, even in adulthood. At least it has been sort of associated with a lot of adverse health outcomes, and these are reviews of these various outcomes. ACEs are very, very prevalent, and at least when you ask in societies, and what is very interesting is that they are very similar. This is a review from Belize, basically showing very similar, quite similar prevalence, null ACEs in the US and in Europe. When combining these data, these are 1 ACEs, 2 or more ACEs. In the SAA cohort, among these women that our cohort, it's quite similar, I would say. So approximately 50% has not been exposed to any, and we have to remember that these can be events all from sort of assaults to parental divorce, or like things that are more often less traumatic. And we have studying a lot of, put a lot of emphasis on studying these associations between adverse childhood experiences. And here we have Tian Yang, who studied premenstrual disorders, and we see that with the number of adverse childhood experiences you've been exposed to, the higher risk of suffering from premenstrual disorders. And similarly, Hilda Björk Danielsdóttir, my doctoral student, studied resilience using 2 methods, either sort of a perceived coping ability and then sort of the absence of various symptoms, depression, anxiety, sleep disruption, binge drinking. And so the more ACEs, the less likely you were to score resilient in adulthood or when you responded to the questionnaire. But obviously, Hilda, who is a twin herself, wanted to delve a little bit more into this question and leverage the Swedish Twin Registry to determine the role of ACEs in adult mental health disorders when taking into account familial factors. And we were very proud to be cited by the New York Times that sort of picked up our study. But here we basically leveraged 25,000 twin individuals in the Swedish Twin Registry. There were 1,500 pairs, dizygotic twin pairs that were discordant on ACE exposure, and approximately 1,000 monozygotic twin pairs discordant on ACE exposure. You see that here at the bottom of the flow chart. I'm not going to lead you through all of these. Yes, and what we saw, we followed these then in the registries for their first incident psychiatric disorder. And sort of in the cohort analysis, we basically saw a 50% increased risk of psychiatric disorders in adulthood by each score, each increase in ACE, by increase of 1 ACE. And we saw that this effect was quite attenuated when we confined the comparisons to the sibling or the twin pairs, the dizygotic and then the monozygotic. The effect was quite strong when we looked at 3 ACEs or more, and attenuated, but still very apparent with both monozygotic and dizygotic twins. And here we are looking at the individual disorders, depressive disorders in adulthood, stress-related disorders, anxiety disorders. And basically we saw the effect sustained for these disorders, both in, although attenuated for all of these except perhaps the substance use disorders. And then when we looked at the different sorts or types of ACEs, from family violence, emotional neglect, physical neglect, physical abuse, sexual abuse, we saw that particularly, and of course these are varyingly as exposure familial. I mean, there was a high concordance for family violence, obviously, while there was not the high concordance and high discordance, I would say, for the sexual abuse. And these were sustained, the risks of subsequent psychiatric disorders were sustained even in the when confining the comparison to monozygotic twins. So this study basically both confirms well, that was our interpretation. That there's definitely an unfamiliar component in these associations, but there's still, when we maintain that we still can be quite sort of clear that there's still an effect when we compare monozygotic twins, that one is exposed and the other is not. So conclude that this picture is from my hometown in the north of Iceland called Ólafsfjörður. Just a view of that. It's on the other side of the Icelandic island. Just to conclude, the Nordic multi-generational registers, they are useful for evaluating time invariant confounders that cluster within families. The full sibling comparisons that we have conducted suggest relatively minor influence, but in some there is definitely like traces and clear evidence of familial components. I just wanted to have these references because there's really, really interesting work being done by this Danish group of leveraging the multi-generational registries, both in Sweden and in Denmark, for sort of looking at genetic liabilities and the phenotypes that we have registered there, using the cumulative incidence in the sort of in the general population, and then cumulative incidence among birth cohorts that have a relative that has the index phenotype. And I think this is really interesting. And I am following this closely and wanting to implement this in our own research. So these are the references for that. And I end with my beautiful group, Swedish Icelandic group, where we were meeting for the first time after COVID in Stockholm. So a mixture of a very international group united in Stockholm in 2022. Thank you very much for listening and attending to the seminar.